presentation. She can share the policy brief. So part of the engagement that we are doing as we're implementing this project with HIVOS, this project is called Comprehensive Sexuality Education for Deaf Adolescents and Young People. So part of that project is reviewing the policy, that is the reproductive health policy, that is running till 2027 from the year 2022, and we are going to be finding out what does it say, particularly about issues of people with disability, with a focus on young people and access for young people with disability in sexual reproductive health. So I see Evelyn has already put on her camera. I'm going to hand over to Evelyn to be able to share with us what we were able to find out from the policy review processes that I'm sure some of us already engaged in during the youth engagement. So over to you, Evelyn. A reminder to those who are using sign language interpretation, we have Liz, who has been pinned, and also Catherine Semaloi. If you're not able to see her, although I know I have pinned her for everyone, if you're not able to access her, please communicate to me on the chat, and I can be able to help you find the sign language interpreter. Over to Evelyn. Thank you.
Okay, thank you, Pamela, and Fedwin community for this opportunity to work on this assignment. For those who don't know me, my name is Evelyn Mataya Amunga, and my sign name is this. This is my sign name. Yeah, I'm a community development professional with interest on matters on sexual reproductive health and rights, and I'm a person with lived experiences on matters with disability. So I don't know if it's right to share the presentation. Pamela, kindly confirm.
Yes, please share the presentation.
Okay, thank you. Okay, thank you. Thank you. Just a minute. Is it coming? Sorry.
Yes, we can see your presentation now.
Okay, thank you. So we have been working. I'm just picking up from where our director left about the issue of inclusive sexual and reproductive health. And yes, indeed, there is a gap from the book of things on the inclusion of people with disabilities when it comes to the right to inclusive health, not only that, just health, but quality healthcare and service provision. So through the assignment, we wanted to dig deeper into understanding why is it that people with disabilities and with more focus, the deaf adolescents or youth, are still suffering from the effects of non-equality in healthcare provision, despite having frameworks that support inclusive healthcare and services. So through the presentation, I will have the introduction, the purpose and objective of this presentation, a national reproductive health review and analysis. I'll share the approach and overview, and then share key findings of whatever we did, and then we'll gather recommendations from all of us who are here. So we have the project that is actually made us to be convened on this platform, the Comprehensive Sexual Reproductive Health Rights, Education and Services for All Deafs project. The goal of the project is to strengthen policy engagement mechanisms that promote the inclusion of deaf adolescents and youth in SRHR frameworks and services delivery systems in Kenya and across East Africa. But now, when the project is being implemented, there are some gaps that have been visible through the implementation of the project, and Fedwin wanted to know why is it that we are addressing the issue of sexual reproductive health among the deaf adolescents and girls, but we still find gaps. The deaf adolescents and youth, they are not getting services, they are not coming out to seek for SRHR services. They are also being hardly hit by the impact of lack of provision of sexual reproductive health rights services. And that's why we sought to have this engagement. Actually, as I had said, we have 89% of deaf adolescents uh, uh, who lack basic sexual reproductive health education. This is from a confirmed record and research that are there within our disposals. And only 35% have access to HIV prevention information. This means that almost 65% of adolescents and youth uh, uh, are not uh, are not accessing uh, sexual HIV prevention information. There is no there's no also formal representation of deaf youth in policy making, and healthcare providers lack Kenya Sign Language, and they're not adversant with the deaf culture, and there's lack of sexual reproductive materials and tools in formats that are accessible to deaf adolescents and youth. So, despite all this, we have the National Reproductive Health Policy, which was developed in 2022, and it will be serving us up to 2032. So, we wanted to know that to find out why is it that uh, despite having the policy and it's 2 years down its implementation, we still have these gaps. And we all know, understand that the policy goal is to ensure that all citizens attain the highest possible standard of reproductive health throughout their lives. So we wanted to understand what is it that is working well within the policy and the gaps that are there, which we can suggest recommendations. So we understood the framework, the National Reproductive Health Policy, and its objectives, which are in good spirit to enhance the access and equity, improve health outcomes, promote adolescents and youth health, strengthen health system, advance rights and accountability, and foster research and innovation. So these objectives are general to the whole public, to the whole Kenyan citizens. But now the focus area is on the universal access for vulnerable and underserved population. The policy also focuses on reducing maternal and neonatal mortality, education services and empowerment for youth, infrastructure, workforce supply chain and financing, reproductive rights, gender equality, and and evidence evidence driven solutions. So the context of the National Reproductive Health Policy, it's actually good and for our benefit because it aligns with the Disability Act that we have the previous 2020 2005, but now we have the 2025. It emphasizes equity and inclusion. Also, the policy reinforces Kenya's commitment to uh, Convention of the Right of Person with Disabilities, the CEDAW framework, the ICDP 25, and as well as the SDGC alignments like the good health and well-being, gender equality, and reduced inequalities. But now, when we dig deeper into the comprehensive analysis of the policy with focus on inclusion of deaf adolescents and youth, uh, we wanted why were we digging deeper into it? The rationale behind our review and analysis of the policy uh, is the policy context and barriers to inclusion. Despite having it, we still have barriers to inclusion, as well as the universal sexual reproductive health lacks focus on the deaf, as well as invisibility challenge. We find that the deaf adolescents are not invisible within the national reproductive health policy, and within our communities, we still have systemic barriers that also transcends into the government sphere. Now, in our analysis, uh, in our review of the policy, we like to share the approach that we used, and we cannot run away from the intersectionality. We recognize that we have overlapping identities and exclusions. We find that as far as people with disabilities suffer from intersectionalities, also deaf within the disability itself. The deaf people are also marginalized within the disability. So we had this approach of intersectionality, and we also had this approach of right-based framework, whereby it's anchored within our legal frameworks, both regional, uh, universal, and also within the country. The frameworks like the UNCRDP, United Nations Convention of the Right of Persons with Disabilities, the CEDAW, the 2010 Constitution, and even the Disability Act. Our approach was also participatory. We engage deaf youth at all stages, from the design through the implementation up to now. We are the deaf youth at the center of it. Uh, we also had tools that are friendly, uh, that they are designed to center on sexual reproductive health right, the tools that we are using to gather feedback. And we also wanted to ensure there's relevance, there's ownership, and whatever we are doing can be sustained. Now, when it comes to analysis of what we worked on, we used the policy triangle uh, policy, whereby we analyzed the context, like the Kenyan context, where we are at the moment, the process of SRHR, and the also key findings, the content that we found, and also the actors. Now, where we talk of actors, we do not just focus on the deaf youth, but we also focus on other players and other stakeholders within the sphere of sexual reproductive health. So the methodology that we applied, we used the quantitative, qualitative, and integration. So we use the mixed approach. So the purpose and scope of the review and analysis, it was just to support a policy framework that address sexual reproductive health for the deaf adolescents and youth, because we cannot have the policy frameworks that are leaving people behind, are leaving a segment of the population behind, or within its implementation, it doesn't capture the lived experiences of those people that it's aimed to safeguard. So the specific objective, as you can see, we had the policy alignment with disability rights. We wanted to know how does it align with it, the accessibility, participation, data indicators. I also wanted to benchmark the global best practices. How is it, what is working in other countries like Uganda, like Rwanda, South Africa, when it comes to deaf inclusion, and also how can we monitor the systems, learn, identify the emerging issues and the best practices that are in place. So the analysis criteria, we analyze the relevance, accessibility, legal rights dimension, sustainability of the policy, effectiveness, the relevance, accessibility, legal rights dimension, sustainability, and its effectiveness. So when it comes to relevance, we had the key questions that are there, but we'll be reviewing. I'll be sharing the key questions and the feedback as we address each and every criteria. And I want to just to pass by, in case you have any question, just drop it to the comment section, or you can note it down at the end of the presentation. We'll share our questions. Kindly, if you have any question or comment or input, don't hesitate to note it down. Either drop it in the comment section or write it down. We'll share at the end of the presentation. So The survey, as I had shared, its purpose and the methodology, and we were able to carry out survey into 19 counties, but with more focus on, we had the more counties of priority like Nairobi, Busia, Siaya, and Trans Nzoia, but we also wanted to get feedback from other counties. So that's the this is the, let me do this. I think this one can be better. I've lost everything. Just a minute. I hope it's still visible from your end.
Yes, it's visible.
Okay, so those are the counties that we did the survey just to understand how the policy is working and how deaf youth are interacting with sexual and reproductive health rights. Uh, uh, on the sorry, on the methodology, we use the qualitative advocacy focused approach, and the sample we did not have the calculation one. That one we did because the emphasis was on representation and not on the formulas. Yeah. So when we come to disability percentages, we had 120 responses, and out of the 120, 37.5% had disability, and 62.5% did not have any disability. So we wanted to have an inclusive feedback so that we are not skewed towards people with disabilities giving information that is relevant, but we wanted also to get feedback from other people who do not have disability, as well as those who are involved in one way or another. Now, according to the Kenya National Bureau and UNFPA, we understand that 2.2% of Kenya population identifies as person with disability. So by this survey, having 37.5% people with disabilities, I think this is a clear indication, and you will agree with me that the sample was from a targeted and inclusive population rather than being just for people with disabilities. So this is the summary of the number of individuals by role or and affiliation across the counties. And as I had mentioned earlier, Nairobi dominated, and we also had Taita Taveta and other counties below who had one voice or just one voice or just to get the feedback from one, but now more focus was on Nairobi, Busia, Siaya, and Trans Nzoia counties. And then we brought in other counties like Kisumu, and Kiambu to balance, and Baringo to balance with like 3 to 5 feedback. So on the first question, we wanted to understand the relevance of the National Reproductive Health Policy. From the context, the sexual reproductive health is highly relevant for deaf adolescents and youth, especially in light of the triple threat. We understand that at the moment, HIV, GBV, and teenage pregnancy is at its peak. And we are trying to see what can be done to address it by the time we reach 2027. We don't want by the time we reach 2027, now it's when we realize that the deaf youth were left behind. And from the marginalized lens, deaf youth face compounded vulnerabilities due to the intersectionalities, as had mentioned earlier. And also you have the cultural insensitivity among the communities within our country. Even within our health facilities, we have the cultural insensitivity. So the questions we pondered, we had this question: does the current national reproductive health policy reflect the needs of deaf adolescents and youth? And then the second question: to what extent do you feel current national reproductive health policy reflect the lived experiences of deaf adolescents and youth? And then which areas of your life are least addressed by current policies. For the last question, we wanted to know, because we find that even if you have the health policies, but other policies that are not geared to health can contribute to somebody's access to healthcare. Let's say a policy on employment, a policy on education. If somebody is not educated, and then also that lack of education can trickle down to her or his willingness or capacity to seek sexual reproductive health services. So the findings, most of the uh, uh, respondents were slightly or moderately aligned, and fewer responses indicated very much to the questions. This suggested that there is partiality in recognizing the deaf youth's lived experiences. Most of the lived experiences of youth are not incorporated in the policies. We also had engagement, physical focus group discussions with around 20 youths from Nairobi, Kajiado, and Kiambu counties on the same matter. And the issue was, it came out clearly that their lived experiences are not captured in these policies. So things like sexual reproductive health and rights, uh, like it's least addressed. The policy doesn't really address it to their satisfaction, and this does not only capture the deaf, even the general public that we interacted with our questionnaire responded to it that from the understanding, the deaf youth, it's not really relevant to them. So, rating by category, uh, sexual reproductive health, uh, it was either not at all or slightly, which is severely underaddressed. Social inclusion, poorly addressed. Healthcare, it needs improvement. There's slightly and moderate responses. Employment, slightly and moderate. We had mixed experiences. Uh, and then education, moderate and slightly. Some inclusion, but we had gaps. But we had other responses that were not clear, which means that there's also we need to do, it's an area that we need to do some research to understand the emerging issues, things to do with intersectionality and all that. So uh, according to the frequency, as you can see, SRHR was spotted by 41, and then we had social inclusion 38 respondents, employment 34, healthcare 26, education 15, and others 3. So this cites that from when we interpreted it, uh, the SRHR has more gap as compared to education policies. Then the second dimension of review the implementation of the policy was the accessibility. We wanted to know, is the services accessible to deaf youth? uh, if we have sufficiency sign language learning resources and tools within our healthcare centers and education system, as well as the infrastructural gaps. So these are the questions that we asked the respondents, and the feedback on deaf inclusion services, sign language interpretation was mostly available, but it was mostly available in in cities like Nairobi, and also in major county hospitals. The sub-county hospitals do not have the sign language interpretation, and also schools that are not at the national level, the normal schools don't have sign language interpretation unless for a few selected areas that benefited from interventions of other donors. We also had the question on peer support programs. It's mostly unavailable. The ones that are available are also being supported by non-governmental organizations. Visual educational materials, they are mostly unavailable. They are available in a few hospitals, mostly at the county level. Then staff trained in deaf culture and evenly distributed and it's mostly in the urban areas. Other services like seminars, there was inconsistent in it. Then when it comes to participation, I wanted to know how deaf youth are engaged in development of policies, review of the policies, and even the implementation of the policies. So participation is not only just participation, but when we talk of participation, we mean that meaningful participation. So the review process, we have the issue of tokenism versus inclusion, uh, whereby deaf adolescents and youth are rarely involved in designing programs. Their lived experiences are not even uh, felt in the policy dialogues, even in programming. This means that even when it comes to implementation, they are not part of it. So we had from research and from what you can see as per now, organization like Federal is leading in ensuring bridging that gap, but wanted to understand from our respondents. So we pondered the question if the deaf adolescents, the question as you can see, are deaf adolescents and youth engaged in SRHR policy development and review processes? Are deaf adolescents and youth engaged in SRHR policy development and review processes? And then were deaf youth and their representative involved in developing national reproductive health policy? This was in 2022. So on participation, we found that there is gaps as most of the deaf are represented by the organizations. By themselves, they are not really on the table, but most of them, they say that they are being represented. So there's that heavy reliance on representation by organizations, and some people say that they are not, they don't know, they really don't know if even we have those policies. This means this suggests that there's communication, poor communication, and transparency about policy processes. Because we believe when policies are being designed, we need to have, they need to be co-designed in a participatory manner. Yeah, so we have 20 plus presented by organization, 10 plus they were just consulted in meetings, and when they are consulted, they are not sure if their feedback or their input was incorporated. A few participated, but others they really don't know. So this is the representation. As you can see, almost 60 respondents say there are no involvement, and we have unjunk like 40 who don't know. This means that the communication dissemination of policy message information is not done right. Then a few were represented in drafting. Okay, so we see we have other unspecified and those who don't know. Uh, it's almost around 50. It means that we need to do research or there are some unmet emerging issues on policies that we really need to be keen on as people who are interested in policy matters. When it comes to effectiveness, I wanted to know if it's the policy, sexual reproductive health right is inclusive, and if the system are in place and how they are working and the feedback. So the question we were asked on that, based on that, the limited impact, knowledge gaps, and service delivery. We wanted to know where the gaps are, and from the feedback, uh, majority of the responses they said no. A few said yes and maybe, which those who said yes, they had also a comment at the end of it, which suggested that something that is lacking. So this indicates that the systemic gap in accessibility, communication, and cultural relevance of sexual reproductive services for deaf adolescents and youth. So as you can see from the analysis, there are systems to monitor, the system that are there to monitor impact on deaf, they are not really there. Even when you see the tools that are being used, they don't capture to generalize disability. even the deaf alone. So we see that gaps coming in clearly. So you can see, I'm sorry, I'm using you can see, but I understand some of the participants might not be limited to seeing. I'm sorry for that. But for those who can see, we have a visual representation of whatever I've said when it comes to inclusive sexual reproductive delivery, monitoring, and feedback. Majority, over 58%, over 70%, 65, they said that there's a gap. There's a gap there, and a few, less than 35%, said yes, but again, they had a comment on that. So when it comes to sustainability, wanted to know if they have institutional mechanisms to sustain inclusive SRHR practices, because whatever the policy is saying, or when the a non-governmental organization comes to support SRHR practices within our facilities, how sustainable are they? Do we believe inclusive services for deaf will continue a long time? And what's the threatened sustainability or the challenges? So the feedback we received, most of the feedback were not sure if the sustainability will be there, and majority said no. They really said no, a few years and maybe. So where maybe indicates maybe the institutional support is lacking, and also there are not that frameworks to support sustainability. We have enforcement gaps also as well. So those were some of the comments the respondent shared. Now, challenges threatening sustainability. We wanted to know which challenges challenge sustainability. And what first thing is lack of funding, because if you don't have funding, then it will not be able to employ uh, sign language interpreters or even conduct training uh, activities. Also, lack community support. This is from the lack of community support. Maybe they have negative feelings, people with disabilities and deaf, staffing issues, communication barriers, stigma, limited resources, and lack of services. From engagement we had with the deaf youth, they said that they don't prefer having sign language interpreter employed in health facilities, but rather those who are employed to be trained on deaf culture. The curriculum needs to incorporate the sign language and deaf culture as part of the curriculum. This is more sustainable and it's cost effective rather than employing a sign language interpreter on a different budget note. When it comes to legal and right-based dimension, wanted to know the policy gaps because Kenya has ratified most of the international and regional legal framework, even have the African Disability Protocol and other frameworks. But again, we have a rights violation. And according to the UPR recommendation and commitments, Kenya committed to ensure that there is that inclusive and accessibility to healthcare. But now, wanted to know if people are aware of these laws so that they can monitor the implementation. Or even when you are doing advocacy, you advocate based on what you know, not on suspicion. You cannot go and say that you want good health care, but if you ground it on policy or on a legal framework, then it comes easy for you to push your advocacy. So those are the question we ask. The second question, does the policy uphold the right of deaf youth as enriched in the national and international legal frameworks? And do you feel your rights are respected in SRHR service delivery? This one focused generally to all people, including the deaf. So we had mixed responses. There are significant number saying they don't know the law or they are not aware. And when it comes to upholding the right of deaf youth, many respondents said that they know, the issues of deaf or disability are enshrined in those legal frameworks, but they are not practical. Implementation is not done. It's just it remains on the paper. So a few indicated no, and I don't know. This reflects a limited understanding of policy content. So we need to also do a lot of awareness creation on these policies. So the last question, do you feel your rights are respected in SRHR service delivery? There was sometimes and rarely. And from this question, we identified the gaps in awareness, creation on legal protection and frameworks. So we also identified the gap in implementation of the policies, and most of these SRHR services, they fail to respect deaf youth rights with just poor treatment. So this is, we have visual representation within 85 and 18 with 16%. So the key takeaway from the legal and right-based analysis is that while sign language interpretation is relatively widespread from our survey, this is in the urban areas and at the county level health facilities. We still have, we lack peer support, visual materials. This is that visual materials is just easy. Having some an arrow directing a deaf person doesn't need a lot of budget, but we don't have them. And this is maybe because the staff there, they don't understand the culture, the deaf culture. So they even don't know if we might need a deaf person. So from all the analysis, all the dimensions, the relevance, there's urgency to address the issue because of the triple threat and accessibility. We also have urgency to provide deaf resources and tools on participation. At least it's kind of because we have fund youth-led deaf organization working on it. So it doesn't need that urgency, but medium. On effectiveness, it's high. We need really to develop deaf-friendly services protocols and train healthcare workers on Kenya Sign Language and deaf culture. Sustainability is kind of medium because uh, we have organization working on them, but now when it comes to limited donor funding, it becomes short term, they are not long term, those projects. Then legal and right based, it's medium to high because we, at the moment, Kenya committed to UPR and SDGs. So we need to monitor, advocate, and follow up, advocate for the implementation of the commitments. So we had the limitations of the survey. We understand that the project is not being carried out in the whole country because of the nature of programs. And we based our analysis as well, the secondary data, from project documents. And from the baseline, we had 60 respondents from 4 counties. But in our survey, we had 120, actually there were 125 from 18 counties. So the data, the feedback we received could not be the same. The baseline targeted teachers, deaf youth, and parents. But for the survey, we extended it to policymakers uh, and other people in the community who are not, it was general to the public. So we tried to find out data from other contexts, but now, based to the baseline, we expanded it to not only, we did not limit it to teachers, deaf youth, and parents, but to service providers at the health facilities, policymakers, and the general public. Uh, our Our review, we did burden-based sampling. As we said, we had 120 respondents from 18 counties. So we made it bigger than the baseline survey, and the target, as I have said, it was deaf youth, parents, service providers, educators, and policymakers. So when it comes to addressing the limitations, we used the mixed method, triangulation, the triangle that I shared approach, and we also ensure that the context was within our focus when it comes to our survey as compared to the baseline survey. So the time constraint also, with survey you want to extend, you want to push it further, but also we need to work within the timelines. So we used the mixed method and triangulation and contextual interpretation. So for respondent trust and ethical safeguards, we working on that. We ensured privacy. We do not indicate names, but also the information we received is majorly for the purpose of improving SRHR services for the deaf and no any other purposes. And whatever we received will be in the custody of Fedwell. Data availability challenges. Yeah, we had a challenge on accessing disaggregated data, which is not there in most cases, as most of the healthcare services, they don't have disaggregated data. Even when it comes to GBV reporting, they just lump women, youth, but at some point we find that other intersectionalities like the LGBTQ are being disaggregated. But now when it comes to person with disability, it's just lump sum in one thing. So that was also a challenge. So as you can see, HIV data limitations and GBV data limitations coming from the GBV, KDHS, and HIV surveillance and outreach reports. All the data is just they don't subdivide it on disabilities. So from the review, we have some lessons we learned. The first one, symbolic inclusion is not enough. We need to be practical and realistic, and you should not we should not exclude anyone. It should not just be symbolic. It should be practical. Then data visibility fuels exclusion, as I've mentioned. Communication barriers undermine access. Commitments must match implementation. When Kenya commits to CRDP, CEDAW, SDGs, and other legal frameworks, we need to see implementation. Technology must be inclusive. We find that we have apps that are being used in some facilities. So we need to embrace technology. We are moving to the second world. We cannot just sit and complain we don't have silent language interpreters, but we can use technology to improve it. So healthcare needs cultural competence, yes. So if you are just a nurse or a doctor without values, then it comes to issues of mistrust, misdiagnosis, and treating some people like the deaf with ignorance. We also need community efforts in policy implementation. Fedwin projects, all of the projects of Fedwin show promising impact when they engage with the community. So grassroots also can work, and we need to scale up our implementation of projects to community-led interventions. Another lesson we learn is that sexual reproductive health right is a right imperative. So exclusion violates dignity to human life, and we need to prioritize the marginalized communities. Then deaf youth are agents of change. I've seen it. If you can focus on building the capacity of deaf youth, then they will be the agents of change, and they'll help us to move forward with our advocacy to ensure that the national reproductive health policy is cognizant of their needs. Because if a deaf youth stand up to speak on it, it carries more length when she's speaking to a policymaker as compared to any other person. And then the last thing, education must be inclusive. We say that education ndio msingi wa maendeleo, but if we don't have education, then it will cut across on our even capacity, even to seek SRHR services. So findings, the key challenges in inclusive SRHR. We have the policy blind spots. This is just a summary, but we have been noting them down. Service delivery also have gaps. We have gaps in education, governance. There's exclusion of deaf youth. They are not on the table. They are not consulted. We still have cultural barriers and data invisibility. So we wanted to know the cause and effect of the issue at hand. We have the one-size-fits-all policy where disability is just generalized. This leaves out the deaf youth. Lack of disability-centered governance. Policies fail to reflect lived realities of deaf adolescents and youth. Marginalization of sign language communication. We have communication barriers, cultural stigma around disability and sexuality. When we are having FGD, there's a youth who said that the LGBTQ within the deaf are now being stigmatized further on top of their disability of being deaf. Then the issue of data and exclusion from decision-making spaces. So if these are not addressed, we'll have continued high rate of SRHR adverse outcomes among deaf adolescents. The triple threat by the time we reach 2027 will not have positive feedback. We'll still be reporting negative. Deaf youth will continue to delay or avoid healthcare due to communication discrimination. Policy goals will still leave people behind. As far as National Reproductive Health Policy speaks of leaving no one behind. But if we continue with the same, we'll still be leaving people behind. Human rights concerns, Kenya is a signatory to NCRTP and other legal frameworks. And then the social cost, we have the burden from preventable outcomes of inequalities. So the strategic pillars of inclusion have the policy reform and governance, whose objective is to embed deaf inclusion in SRHR, and then the key action to amend the policy. Actors, we have the Ministry of Health, National Council of Disabilities, and Governors Council. So this one you can give it, we thought it's 1 to 2 years. These are the recommendations, but we'll also need to get your feedback on it. Then capacity building, need to train educators on Kenya Sign Language, train inclusive SRHR, institutionalize deaf culture, and also interpretation. So the actors, you have the Minister of Education, KMTC, and county health departments. This is a midterm issue, can take 2 to 4 years from now. Then interpreter access. We need to ensure that we have qualified interpreters in SRHR settings. We need to recruit interpreters and set standards. The person responsible will have the National Council, the Interpreter Council, and the county government. This can take 1 to 3 years. And then access to information. The objectives to provide SRHR for deaf-friendly formats. We have the key action you can have videos, visual campaigns, and tech-based tools. Here we need a lot of innovation. But actors, we have the ICT, NGOs, and the media. This is something that is ongoing because we have the apps that are being used at the moment. So it's something that is ongoing, but we can monitor and sensitize the actors to ensure that it's taking effect. And then the health system adaptation, we need to make SRHR service inclusive. So the key action to to advocate for budgetary allocation, advocate for deaf-friendly units, and inclusive infrastructure. So the actors, we have the Ministry of Health, counties, and development partners. This can take 2 to 5 years. Then community engagement, we have supportive environment for deaf youth. Key action, we have the educate families just to reduce stigma and all that. So actors, we have the religious leaders, ministry, and other leaders. This is something that is ongoing because you can see Fedwin working on it. And then data and evaluation, we need to track deaf inclusion in SRHR. We need to advocate for the tools to be disability sensitive, not just to lump female or people with disability. We also need to disaggregate data when they are being collected. So this one we need to follow up cleanly with Kenya National Bureau of Statistics, Ministry of Health, and civil society for advocacy. So this one we can give it 1 to 10 years because we can see the results even from, we can start to measure and the outcome from even 1 year. Then financing and legislation, we need to do a lot of fund and legal support, inclusion advocacy, and earmark budgets to include in the universal health coverage. We should align with the CRDP recommendation that deaf sign language interpreters need to be budgeted for. We need to have inclusive SRHR service provision, and this should come with budget allocation. So this one can be implemented within 3 to 10 years. So my parting shot, I borrowed from Dr. George Lutomia. Policy analysis is not about finding the perfect answer. It's about providing decision makers with the best possible choices, backed with evidence, clarity, and integrity. At the heart of it, good policy analysis helps societies make better decisions today for a better tomorrow. So thank you so much. Open floor for feedback. Back to you, Pamela.
Thank you so much, Evelyn, for such an extensive sharing and an explanation of what we expect, what we have seen, and what is happening in terms of policy and in terms of implementation. So anybody that is in the call that would like to ask any question, this is your opportunity. I see we had several comments in the chat. We had Helen who said, let me just read her comment. We had Helen who commented and said that in schools about interpreting services, is this about deaf schools? And if yes, there has never been an interpreter since time immemorial. Most deaf rely on teachers, and the same teachers, most of them are not qualified in sign language. That was a comment from Helen Nadine. And we also had a comment from Owino Okelo, who said, despite these policy aspirations and legal protections, there are many indications that deaf youth are not fully accommodated. For instance, lack of sign language interpreters at health facility or during health education. Thus, important information about contraception, puberty, consent, etc., does not reach them. So these are the two comments that we got on the chat while you were making your presentation. And we also open the floor to any other people that would love to comment on whether we agree with the data that has been collected. Do we find it factual or not? Do we have any feedback? Have we been able to identify any gaps that have not been discussed that we are experiencing on the ground? So this is our time to comment and share our feedback on the presentation that has been made by Evelyn on the policy review and the surveys that were able to be done from the respondents that participated in the exercise. So over to you, the floor is open. We are open to hearing the comments, any feedback that we could have. If the information that has been shared is also correct, we are hoping to hear from you so that we are able to validate the policy review that we were able to do. Thank you. So the floor is open to any respondents who would like to say something. For the deaf community, if you need a sign language interpreter, I know we already have one. You can just switch on your video and you could raise your hand also so that you're able to comment. So I see that there's a comment that Videlis has a question. Maybe I'm not able to see her hand raised, but I don't know if the interpreter can see Videlis so that you can take Videlis' question.
Yes, I can see Videlis. All right. I just wanted to ask about the facilitator talked about that we need interpreters, and also the council should be involved. So I do not understand where they're involved, because she said we need to have interpreters, like the interpreters council. I do not understand. Maybe I do not know whether there's an interpreters council in place or something. So I want clarity about this. Thank
Okay.
you.
Maybe to respond on that, we have Kise.
Just a minute, Madam Sylvia. Josephine is talking. The facilitator was trying to talk about KSL bill. So she was proposing that they want to form the Council for Sign Language Interpreters to regulate interpreters' work. As we look for a way to make communication gap, maybe to bridge the communication gap, to provide interpreters in the hospitals, to break the gap that we have now. So as a deaf person, I prefer a long-term solution, a curriculum in KSL to be included in the institutions of learning, where maybe doctors are in primary, in high school, in colleges, in medical colleges, so that when these graduates come out of school, they are able to communicate basic sign language to the deaf community, to give the deaf people opportunity to talk directly one-on-one with the doctors and nurses, so that this will reduce the third-party issue where an interpreter is involved. So when you have an interpreter as a third party, the confidentiality issue is broken, because I do not want to reveal my health issues. I'm not free enough to share my issues. Yeah, so it's not accessible because the service providers, they do not want to use sign language for a long time. So we are dreaming of a day where we find a nurse or a doctor or a police signing to us directly. That is our long-term dream. So, and we believe we will achieve this. So when the KSL bill is assented, We are, it is there in Parliament. So this is just a temporary solution, not a long-term solution, because what we really need, what we are advocating for, is for everyone, all service providers, to have at least basic sign language skills where we can communicate to them directly. Yeah, so that she was trying to answer Videlis.
Okay, I see Videlis has already put out their video. I don't know if the answer was comprehensive. And just a reminder to those of us who are running on the call, please remember to register your name on the registration form on the link that has been shared on the Google Sheet. Okay, see Videlis is still speaking. I see you're saying there's a problem with the Google Sheet, but I have noticed that many people have been able to register their names. So I have pinned the message again. Let me pin it right now. Just click on the Google Sheet, on the link, and you will be able to make an edit. You just add your name onto the list that has already been started. All right, do we have any other comments? I can read the comments in the chat while we take any other question that our participants might have for the presenter or our facilitator for the day. I see Margaret Okoth has said, since I am in a deaf school, we do interpretation to them both in class and whenever it is a school activity happening outside. My major worry is when they are at home. Most family members have not gone to the extent of learning Kenyan Sign Language to aid in communication at home, although I want to applaud some for doing the course to isn't that at home. In hospital, this is yet to be done. I wish it could be carried out as soon as possible. Okay, so we agree with that. I think we have heard that also from our facilitator, that there is a gap that we still are yet to realize with access to sign language communication in the healthcare facility. So as we have heard, we have policies that are talking about this, but not much has been done in this regard, which is a question that begs for our attention and it begs for us to do more, right? To do more policy work, to do more engagement, to also do more lobbying so that we are able to see these policies that have already been ratified that talk about access to healthcare actually being reflected on the ground. To see that the healthcare facility, as we have mentioned, the healthcare practitioners being trained while they are still learning in colleges and in universities, having access to basic sign language training so that they're able to provide inclusive services at the healthcare facility. I know in Kenya, particularly in Nairobi County, we have a few healthcare practitioners who have been trained in sign language. Like we have one of those who have been trained, three in from the Nairobi Health Department, who we have trained as Fedwen in sign language, as well as many other healthcare practitioners who have been trained in different sorts of programs. I know that the Ministry of Health is working on a curriculum of training the healthcare workers who are at KMTC, and they're continuing to develop that in collaboration with Jomo Kenyatta University, as well as the Kenya National Association of the Deaf, of course, with Rahab sitting there in that committee as a representative of Fedwen Kenya. So there are many other avenues that are coming up. Maybe we may not have been able to see the fruits, but I'm sure that there are so many more that are going to be achieved in the days to come and in the years to come. So I'll open the floor again for any questions before I lead us into the last segment, where we are going to be doing some few exercises to hear what have we been able to capture, what are our recommendations, and just to think together on a few ways forward that can help to advance inclusive SRHR services, particularly for deaf youth. So I'll open the floor again for any other questions, just so that I don't lock you out before I move on to the next segment of our webinar. I see Helen Nadine has also commented and is saying, the point is knowing health terminologies in case they are being trained, not learning basic sign language. which is a very good point that she raises on the chat, that it is not just about having basic sign language communication skills, but the healthcare practitioner being able to communicate complex health issues with a deaf person in a language that they can understand, not just being able to keep up basic conversations. So in healthcare, we're not just talking about soft conversations of how are you, I am well. We're talking about more complex issues, about access to healthcare, about having the correct signs for the correct health issues. Because I also know that another gap in the deaf community is that we don't have terminologies. Even when we are thinking about sexual reproductive health, even signs for different words, for example, even in contraception, do we have those signs? So this also begs for development of Kenya Sign Language, research in Kenya Sign Language, so that we are able to come up with standardized ways of communicating issues in healthcare, and of course, collecting data in healthcare and disseminating, and also even training our communities on this language and these signs, so that deaf people are able to have a language for health issues that might affect them. I'll open the floor again to anybody who would want to comment in case they would want to say anything. I also see that in the comment section, we have another comment from Helen that says, again, there is a huge gap because myself as a deaf person, I don't know how terminologies like hemorrhoids is signed. How will a doctor know if I am to train them sign language? So that is an example of what I was just discussing, that many of the health conditions, particularly health conditions connected with reproductive health, even when you look at maternal health care, we don't have enough terminologies in sign language for us to be able to adequately explain these issues in a language that deaf people can be able to understand. For example, if we are creating awareness, how will we create awareness? How are we going to talk about maternal health, menstrual health, if we don't have the specific signs for these specific conditions? So it calls for research and development of Kenya Sign Language so that we are able to do more and we are able to create awareness adequately in our communities. I see that Rahab agrees with me. Sign language research is needed to help us update many of the health signs. I agree with you. So we can keep commenting on the comment section. In case there's anybody that has raised their hand and have not been able to see you, please comment on the chat because we are so many. I am not able to see everybody. Just in case you have not been able to see your hand, you can put in a comment on the comment section. And just before I move on to the next segment, I don't know if I will be putting you on the spotlight, but I see that one of our partners is here, Kelvin Kaptula, and he has joined the discussion. Kelvin, if you're able just to say hi to our participants, we would appreciate that. Kelvin is part of the HIVOS Regional SRHR Fund that is currently being hosted in Zambia, and they're part of the partners that have been supporting us to do this work. So if you're able to say hi to the participants, you can have the floor, Kelvin.
Good afternoon, Pamela, and good afternoon, everyone that are joined in this call. Indeed, I have been following the conversation, more especially the information that was being shared with us on the data that was collected. Truly, I think there's a lot that we need to do as partners. From the EVOS point of view, we are very glad to be part of this conversation and also discussion taking place this afternoon. And may I simply say kudos to Fedwin to bring us in the same house to discuss important issues affecting our young people in our communities and countries at large. Thank you very much, Pamela, and everyone. Thank you.
Okay, thank you so much, Kelvin, for your brief remarks. We appreciate you joining us and being part of this conversation as well. Okay, so we are going to be moving on to the next segment. And in this next segment, we just want to see what are the ways forward. Now that we have discussed what is the landscape and what we already know happens on the ground as people that are deaf. I see that a very good number of our participants is deaf people. So as the consumers of the services, what are the ways forward that we would want to see? What are some of the changes that we would want to see happening in the near future? So I'm going to be sharing my slide just briefly, and we can be able to look at that and briefly have an engagement on what can we expect and what are the things that we would want to lobby government to see. So I'll start with a small exercise. I know we have been discussing a lot. We have had so many things. Many of the things we have had are still gaps that may make us feel frustrated as a community, wondering when will these things change? When will healthcare be accessible? You know, when are we going to see improvement in terms of sign language access at the healthcare facility and in different places? So I want to hear from you. You can choose an emoji, or you can also share one word on the chat. And how are you feeling? Are you feeling excited? Are you feeling overwhelmed? Are you feeling like things are not changing? Do you feel like you wish things would change faster? How are you feeling now that we have had this conversation and we have had where we are as a community? I see most of us are feeling good. Does this mean we are okay with how things are, or what does that mean? Because I see very many heart emojis and very many thumbs up emojis. Maybe we can hear from one person. I see Valerie responded with a thumbs up. Valerie, are you able to tell us why are you feeling good? I see also Wino has responded with a thumbs up. Valeria Jambo. This is her sign name. Okay, Valerie will type. All right. I see Rahab said she's feeling good. We have started doing what is essential. Rosette Juma has said she's feeling enthusiastic. Videlis has commented that the presentation was well delivered. Okay, so I see there are more people who have raised their hands, who would want to comment, and we can hear from Owino.
Good afternoon, everyone.
Good afternoon.
I feel so excited because I'm so impressed with the work that you people are doing, especially the work that was represented by your consultant. Based on the research and the gaps that we've been seeing with young people, especially young people with disabilities, specifically for the deaf community. We have struggled working with young people all over, but now when Fedwen is taking up the lead, these are a very positive uptick, and it shows that we really want a community that is equal to everyone. And I had her putting in across the term intersectionality, where young people have their different barriers, different ways that they present themselves, that they face barriers accessing reproductive health. One of them being access to information. I would have seen it as a gap and also as a lesson that we are learning from various categories or where data was picked. And when we advocate for these access information as one of the main barriers, then we are really moving away that we should always involve a young person with disability, especially the age between where you people are looking at between 14 to 28. These are very reproductive age where we really need to access these reproductive health services and even commodities. In addition to that, I've also seen that there's need for advocacy to ensure that sign language interpretation, sign language is learned at the institution where these service providers are trained, so that when they get out of these facilities, this institution, when they go to work, then at least they have information that they can deliver to young persons, especially the deaf. That is a really good uptake, because even when we look at our constitution, we are told that we have 3 national languages, and SLI being one of them. But in real sense, we are really dragging down when it is already our duty that we should be having this language. The challenge that has presented itself that we had not been trained before. So there's need to be trained and to be incorporated in these institutions so that when service providers leave these institutions, they're fully equipped to communicate with either the deaf or even non-deaf community. Thank you so much for the work that you people are doing.
Thank you so much for your kind words. And I agree with you completely, particularly on the issue of intersectionality and the intersectional experiences that we find in the community, because we also have to consider that even the deaf community is not homogeneous. We have different levels of understanding in the community where some deaf people are postlingual meaning that they became deaf after and they were able to access language before. Some are prelingual, which means that they were born deaf. So we have different types of deaf people. We have deaf people who have money or who are of higher social economic status, and we have those who are still struggling or are living in poverty or of low socioeconomic status. And all these people need to be able to access healthcare services, particularly sexual reproductive healthcare services. So we need to consider intersectionality very seriously in the approaches that we are going to be taking when lobbying government and also when implementing and providing access to deaf communities, so that we don't come from a place of assuming that sign language interpretation services is enough accessibility even at the healthcare facility. We should not be advocating for just one way, but different ways that can be able to reach different types of deaf people and even different groups of people with disability. I also had seen somebody else that had raised their hand. Videlis Njoki, you have the floor. Let me try and pin her so that we are able to see. Yes, I think we are able to see Videlis very well. Oh, okay. Okay. I see Videlis saying that she had already asked her question. Okay, so that is fine. Thank you so much for all the comments that have been given and for all those who wanted to share. I also see in the comment section we have a comment from Timothy Olwande, who is saying, this is great if all sectors are included, it will really help. And Valerie Ojambo saying that I feel it is an inclusive webinar. And we agree with you, Timothy, that it is very necessary for different sectors of government to be engaged in this conversation so that we are able to understand the gaps that exist and what we need to do to address these gaps. Because we also realize that the shoe wearer knows how to repair the shoe because they know where the shoe, like where it pinches. So we need to engage communities of people with disability, organizations of people with disability to be able to get the information and know how can we adequately address the gaps that exist in sexual reproductive health and service provision in sexual reproductive health. So I'm going to move on to the next slide of what I had prepared today. And because of time, I will not be able to go through everything, but I'm going to be asking just a few questions that I have put on page right now. I can hear some background noise from, I don't know who it is, but just in case it is you, please assist us with muting yourselves so that we do not have any more disruptions. Thank you so much. So these are the questions that we are going to be engaging in as we end our webinar, just so that we leave with a call to action and knowing what are some of the low-hanging fruits that we can be able to explore in the times to come. So just to engage all of us, of course, the floor is open. You're free to comment on the chat or you can raise your hand and we can hear from you. And the first question that I'm going to be posing to the floor is, what specific actions can your institution commit to in the next 6 to 12 months to support deaf inclusive SRHR? And I know we have very many young people on the call also, deaf youth who are on the call, who may not be exactly tied to an institution, but in the different capacities that we work in, as a deaf youth, as a deaf advocate, or as a policymaker or a policy influencer. What are some of the actions that you feel your institution can commit to in the next 6 to 12 months to support deaf inclusive sexual reproductive health and rights? So I'm going to open the floor to hear from us so that we can engage in a conversation and see what are some of these things that we can do. Over to you. And also to give some additional guidance, it does not have to be very big things that we may not be able to achieve. Just small actions that can be able to bring impact. What are the low-hanging fruits that we can be able to identify of how we can support deaf inclusive sexual reproductive health? It could be either at the capacity of an institution or even as an individual connected to an institution. I don't know if Videli's hand is a new hand or the old hand. It is a new hand. Okay. We can hear from Videlis. Let me pin her. I know Videlis, you work in media and you're also a deaf person. So maybe you can also share with us how can we also leverage media to promote deaf inclusive sexual reproductive health rights.
So I think the key point is we need to first mobilize the deaf community. When we are mobilizing them, we need to be we need to simply know how to disseminate the information. As a person who works in the media station, I know what I can say and what can be done within 6 to 12 months is we need to have a specific day where we can discuss on the topic of sexual reproductive health. We need to share the information because they do not have, and we need to start on the basics. Let's talk about sexual rights, the types. So we need to be very specific because most of them, they do not know the different types that there are, the different rights that they are there. So they need to know that accessing health services is my right. So we can do this day by day. We also need to know every day, we need to make sure that we have a different topic that can be done. We can use different platforms, we can use social media, on TV, and different ways where deaf people can actually be able to access. And when they walk in, they're able to know that they're able to know their rights. Also, we'll also need to partner with the health officers, because most of the time we're talking about sexual reproductive health rights, but do they know? Because sometimes we have to educate them and change the attitude. Because most of them, they do not feel safe. Sometimes you want to express yourself, but the attitude, the perception. So working with the health officers, they need to understand. And so they need to be taught how they can be able to serve the deaf person and how they can access the information. Because they need to express themselves without a worry.
Thank you so much, Videlis, for your feedback. That was very nice. I've heard from you leveraging media, that is mainstream media, television, and the media that is mostly accessed by communities of people with disability to create continuous awareness on sexual reproductive health, just so that the community is able to understand these issues and they're able to know their rights. That was a very good contribution. We've also heard that we need to collaborate more with healthcare workers so that they are able to be trained, they're able to know what the gaps are and how they can be able to adequately serve communities of people with disability. I agree with you completely on that. And also, I think, maybe just to add on this, I think that we also need to be in a position to work with government so that we have sustainable change being realized. Like, for example, I believe one of the key steps that we have been able to see, or one of the achievements that we have been able to see that is coming soon, is the curriculum that is currently being developed that should be disseminated in the Kenya Medical Training College. So we can anticipate that in the coming years, we will see an improvement, particularly in sign language communication at the healthcare facility. We have also other comments in the chat. I can see a comment from Owino Okelo, who has committed to engage deaf individuals, particularly youth. I like that you have specified that we should be engaging youth, because I believe that, especially in the communities of people with disability, we find that stakeholders for disabled communities many times are older generations of deaf people or people with disability. It is very rare that we find youth being engaged in policy spaces and being engaged in policy discussions. But we also know, and we can agree, that the challenges that the youth face or experience might be different from the challenges that may be affecting other people in the community who are older or even younger. So it is good that we have that as a commitment, that in your space you commit to engaging deaf youth in consultations so that policy content reflects their priorities. We also see participatory monitoring to see how policies are implemented in practice. This is very important because, as we had discussed before, the shoe wearer knows where the shoe pinches and knows how to fix the shoe. So we need to engage them to see if the practice that we have adopted is adequate and effective, and if not, how can we be able to make adjustments so that the solutions that we are providing are actually addressing the needs that remain on the ground. Mary Kamwende from Gifted Community Center has mentioned that at Gifted Community Center in Kibera, we use qualified sign language interpreters in all SRHR activities and trainings. We also produce visual materials like our reports, posters, videos, infographics in Kenya Sign Language or with subtitles and simple visuals, including on our website. Hence, our commitment to have inclusive deaf SRHR programs. I like this comment very much because it talks about even different ways that we can support communication access. We can do captioning, we can do infographics, we can do videos, all of these in sign language that then should be able to support deaf communities when accessing sexual and reproductive health and rights. And I know that the Gifted Community Center is a very active partner in the deaf community working on issues of sexual and reproductive health and rights. So I believe that the commitment that you have shared here is actually going to be seen and is being seen even today in the work that you do. Anybody else who has a commitment that they would like to share, you can share it in the chat. And also, we can move on to the next question. And I will probe you further to ask what kind of partnerships would strengthen this agenda at national and county levels. Now that we are discussing SRHR, the gaps that exist, the opportunities that are there, what has already been done, and what is yet to be done. What partnerships do we feel would be beneficial for us as we are engaging in this so that we are able to see inclusive SRHR programming? What are some of the partnerships that we can be able to leverage to be able to make these milestones? I'll throw it back to you. Maybe we can even see in Gifted Community Center, maybe what are some of the collaborations that or partnerships that you would wish to engage in so that you are able to achieve this, and even with the other deaf youth that are on the platform. What partnerships do you think would be able to enhance how deaf youth are able to access sexual reproductive health. I know for one, I can comment on FedWen's side. One partnership that we would like to explore just from the engagement that we have gotten here is a partnership with Gifted Community Center. I believe that we work in the same areas of focus. I know you also work in disability work, and I think we were also in the technical working group together last year for the HIV summit that was organized by the National Syndemic Disease Control Council. So maybe that is also a partnership that we will be able to see that I think would be able to advance SRHR programming if we were able to come up with consortiums and networks, particularly working in the intersection of disability and sexual reproductive health. I think that is something that is very necessary and that is needed in the field. Collaboration amongst like-minded CSOs and OPDs to be able to advance and even amplify the agenda of inclusive sexual reproductive health and rights. So over to others on the floor, what are other partnerships that we think we can be able to leverage? Some of us have not commented. I don't know if I should pick on us or I should allow you to just comment when you have something to say. Okay, I see on the chat we have some comments. We have a comment from Elizabeth Kemunto that is saying, engage deaf youth in consultative forums on matters of policy implementation and also sponsor more people to study Kenyan Sign Language and create awareness on disability issues. Yes, I think this is a partnership that is very necessary, a partnership between institutions and OPDs, that is organizations of persons with disability, to be able to strengthen the capacities of policy implementers and service providers. So that is a collaboration that is very necessary. I see also Owino has commented and said, and she has said, collaboration and partnership for and with OPDs on SRHR. We agree that is something that is very important on sexual reproductive health and rights, reproductive health and rights. So that is something that is very important for us to do. Collaboration between institutions and OPDs, that is organizations of people with disabilities. And because of time, I see our time is running out really fast. Maybe we can agree on a gap that we feel is urgent and requires multi-sectoral collaboration, particularly from the deaf community. I'd want to hear, for those who are on the call, what is the most urgent gap that we have been able to see? So we've talked about different things being an issue. We've talked about healthcare practitioners needing to learn sign language. We've talked about materials being produced in sign language. We've talked about research being done in health to be able to develop signs for the deaf community to be able to effectively address and even discuss issues of sexual reproductive health. So in the list of priorities and even in the many other gaps that we had, we talked about also youth being engaged in policy discussions or in SRHR. So one gap that we can identify that we can say is urgent and we can plan multi-sectoral collaboration on it. What can we say this gap is? So what is the most pressing gap in the community? I see a hand is up. I don't know if I don't know if Videlis is raising her hand or it is the same hand that has been there. Does Videlis want to say something? Because I see her hand is up. I see her hand is up, but her video is not on. Okay, so it's the old hand. I think we can hear from Timothy. Timothy, I've seen that your hand is up. Timothy, you have the floor. Maybe as we wait for Timothy, I can read the comments that are already on the chat. And we have one comment that says, intergenerational dialogues where we involve key stakeholders, where the deaf are the main participant, are the main partners, community CHVs, that is the community healthcare volunteers, the community religious leaders or Nyumba Kumi leaders, because for the longest SRHR issues among deaf is mainly hindered by culture and beliefs. So the reason to have community members and leaders involved is, I think, cultural beliefs and attitudinal barriers have been a big hindrance for the deaf community when accessing sexual reproductive health services. So engaging these different local authorities from the CHVs as the most, as the those who work at the grassroots level, the community religious leaders, because they have a lot of influence in the community and in society, Nyumba Kumi leaders at the grassroots level, and the deaf community as the partners. I think that is a very good idea. And we also have another comment from Owino Okelo, and she says, create safe spaces for deaf youth as primary community and as an advocacy platform based on their lived experiences. Timothy has said that he will type his comment, and Kelvin Kaptula is dropping off at 3:30, which is all right because we should be ending our meeting soon. And Rose Opio mentions that this is a great milestone already. Having this information down to the grassroots will be more impactful. In the spirit of leaving no one behind, we get down to these youths deep in the village, those who are hungry for information, but there is an access barrier. Let's embrace localization so that inclusion is practically achieved. So I'm going to take that as the comment from Rose Opio as the gap that you can identify. I think that is a very good comment, that we need to come up with strategies of reaching the deaf youth or the deaf adolescents at the very grassroots levels, those who are living in the rural institution, in the rural areas, who are not even able to access any type of information, not even through social media or even mainstream media. We need to come up with ways that we can be able to reach them and ensure that they are able to access sexual reproductive health services. So for our closing remarks, I just want us to share something very fast on the comment section. You can pick either one of the questions in one sentence. What does inclusive SRHR for deaf youth mean to you? Or what will success look like 1 year from today? You can respond that to that in the chat, and then we will have our closing remarks and we can end our webinar. So just reflect and think, what does inclusive SRHR for deaf youth look like for you or mean to you and your institution? And what is success looking like 1 year from today? For me, success 1 year from today looks like more deaf youth. I will even put it in the chat, more deaf youth engaging in policy work in SRHR. So that is what success would look like for me, or even what inclusive SRHR for deaf youth would look like for me. So what does it look like for you? I look forward to reading your comments on the chat. And just to remind those of us who have not been able to register, we have a link that we have already set up. Please click on it and put down your details so that we are able to engage you further, even in the days to come. So what does inclusive SRHR for deaf youth mean to you, or what will success look like 1 year from today? Nice. I see we have a comment here, strengthen referral linkages between CBOs and deaf-friendly health facilities. Yes, that is a very good one. That we don't just do the lobbying and improving of the services, but we have strong referral linkages from the community level to the facility that is actually inclusive. That is, I like that comment. I'd like to hear from the rest of us. What are we thinking about? What does success look like 1 year from now before we end the webinar? Margaret Okoth comments and says, it's a good start. The conversation has just begun, and I am so glad that inclusion is happening. Thank you for your comments. Margaret, for Videlis, she says, for me, being inclusive means having a common goal, speaking with one voice, and working together in unity so that everyone feels valued, heard, and part of the journey. Yes, as we always say, the slogan of the disability community is no one should be left behind. All right, so I'm going to keep reading the comments as they come. But in the meantime, I thank you all for your participation and taking the time to join us in the webinar. We really appreciate you. For those who have not been able to put down the information in the link is still available. I have pinned it in the chat. Please put down your details so that we are able to reach out to you after this webinar and to engage with you even more with different types of work that we do and different engagements that we may be able to plan for you to continue this conversation and to continue with the impact of our work. So thank you so much for joining us. We really appreciate you. I am sharing the link again for those who would like to register last minute before we close the webinar. I'd like to request maybe someone to pray for us, anyone who is on the chat, so that we are able to end on a high note and, of course, to end this conversation with God being with us. I have seen also a comment that has been just typed right now before we finish and we close the webinar. And it says that success would mean deaf youth claiming their sexual reproductive health rights without barriers or stigma. That is what success would look like for Rose. Thank you so much, Rose, for your comment. And we'll be sharing also a report from this webinar of what are the things that we have been able to engage in with you in your emails. I hope that you have been able to share with us your email so that we can continue engaging with you. Again, a last reminder for those who have not been able to put down their names. I can see some people are now on the Excel sheet. Please check out the name on the chat. We have shared with you a link so that you're able to register your details. Thank you so much. I see Belinda has joined us. I don't know if she would want to pray. Belinda is one of our youth champions, and I see she was experiencing a bit of internet connectivity issues. So I don't know if Belinda, you're in a position to pray for us. You can just type on the chat if you're not, and then I can be able to delegate it to somebody else. And anybody else who has a comment, please feel free to share your comment before we close the webinar so that I don't lock you out. All right, I'm not so sure if Belinda has been able to see us. Any other volunteer who'd want to pray for us, who'd want to do the closing prayers? Okay, I will pick someone from on staff. Okay, we have Rose Opio. Thank you, Ruth, for volunteering. I think you can have the floor.
That was a really good engagement. Can we believe and pray? We thank you, Father Lord, for the protection that you've given unto us. Thank you for leading us from the beginning of this engagement through to the end of it. Father Lord, we pray that you be with us, even as we plan to implement this. In Jesus' name I pray. Amen.
Amen. Thank you so much, Rezupio, and may you all have a nice evening and a restful weekend now that tomorrow is a public holiday. Thank you so much all for joining. We will engage more on email.